Thank you for joining us. We are now going to start today's webinar. Before we begin, I'd like to go over a few details for today's webinar. To ensure audio quality for all attendees, we have muted everyone's lines. That means you can hear us, but we cannot hear you. Even though your lines are muted, we want to hear your questions. To ask a question, use the chat feature that is on the right-hand side of your screen. You may have to click the arrow next to it to expand the section. We will answer questions at the end, after all of the presentations are finished. With that, I'll turn it over to Dr. Amy Eden, who will kick us off.
Thank you. Hello, everyone. As Director of AHRQ's National Center for Excellence in Primary Care Research, or NCEPCR, it's really my pleasure to welcome you all to today's webinar, which is our second of 4 planned for 2026. But before we get into the main content of our webinar about primary care practice-based research networks, or PBRNs, I wanted to introduce you to NCEPCR just a little bit and share some recent AHRQ PBRN resources. Next slide, I think. Yeah. So as you probably know, as a component of the U.S. Department of Health and Human Services, AHRQ is dedicated to health services research, the field of study that examines healthcare as it is delivered to patients. So examining the quality, safety, and affordability of healthcare delivery. The mission of AHRQ's NCEPCR is to improve the delivery of primary care through the support of transformative primary care research, the development of tools and methods for implementation, and also support for the next generation of primary care researchers. Next slide. NCEPCR focuses on a set of activities to support its mission, and today's webinar hits on a few of these, including communicating primary care research and cultivating a robust primary care research workforce, specifically here through supporting the work of primary care PBRNs. Next slide. And this is just QR code that will take you to additional information and resources about NCEPCR. This is the landing page. And next slide. And to dig into some of these PBRN resources I mentioned, over the past few years, NCEPCR has released several things for PBRN specifically, and for PBRNs who are in different stages of operation. This QR code will take you to a page where you can find all of these PBRN resources, and then the following few slides will give you QR codes or links for the specific resources to take you directly to those. So next slide. AHRQ has hosted, hopefully you're aware, for many years now, a PBRN registry. We recently automated the process for registering a PBRN for the first time or for updating PBRN data for those who've been in the registry. And the registry provides users the ability to go in and search for PBRNs, identify collaborators or resources by PBRN characteristics, like network type, current or past research interests, state of operation. There are also some international PBRNs in the registry, so if you zoom out of the map, you can see where some of those are located as well. Next slide. You can check out our PBRN learning series, which includes 3 sessions. 2 are traditional webinars, and 1 is an asynchronous e-learning course. And while it's geared towards building a new PBRN, it has some really great information and nuggets for more established PBRNs as well. Next slide. Some additional resources include profiles of PBRNs from across the country, and these give a sense really of the kind of work being done on the ground. If you are listening and you're with a PBRN that's not profiled yet, please feel free to reach out to me, or there's also a PBRN, AHRQ PBRN mailbox, and we'd be happy to facilitate getting one created for your PBRN. And then given the unique challenges and needs of PBRNs in obtaining IRB approval, we have a handy tip sheet about how to effectively work with IRBs. And it's full of tidbits from successful PBRNs who've been doing this work. Next slide. So finally, in a few minutes, you'll get to hear more about the findings in this synthesis report that came out several months ago, which includes 10 years of PBRN publications. And that's also available on our website. And I just wanted to point out quickly that the full list of over 900 publications that are synthesized in the report can be found in a downloadable Excel spreadsheet. Next slide. So I hope you'll go check out some of those resources. And for today, the objectives of this webinar are to learn about AHRQ's PBRN synthesis report that I just mentioned, and then to highlight 3 PBRNs and learn about the value and impact of their work. And we have a great lineup of presenters, including the main author of the report and 3 PBRN leaders and researchers who will share their real-world PBRN experiences. Next slide. So finally, I'm very pleased to introduce our moderator for today's webinar, Dr. Sebastian Tong. He's a family physician, a very productive primary care researcher, and PBRN leader. He comes to us from the University of Washington in Seattle, where he is an assistant professor of family medicine. He also serves as associate director of the WWAMI Region Practice and Research Network, which is a PBRN of over 120 primary care practices. He can correct me if I'm wrong on that one. So Sebastian's going to be moderating, facilitating the Q&A and discussion afterwards, after all the presentations are finished. So without further ado, thank you so much and welcome, Sebastian.
Thanks so much, Amy. I'm so glad to be here, and thank you everyone for attending. I think as a practicing family physician, I can say that I've been using the evidence that AHRQ generates on a regular basis in both my clinical and research career, and that my actually first research grant was from AHRQ about 10 years ago that launched my career looking at evidence-based medicine. I was reminded of AHRQ's support for PBRNs yesterday when we had a meeting with our steering committee for our PBRN, which spans kind of the WWAMI region, the Washington, Wyoming, Alaska, Montana, Idaho region. And we had members from Idaho, Montana, Wyoming talk about how PBRNs are really helping bring evidence to their mostly rural states. So it's really great to be part of this kind of webinar and to introduce our 4 speakers that we have today. The presenters will talk about the values and impact of PBRNs, and our presenters are Asta Sorensen, who's an independent consultant, Melinda Davis, who is at OHSU and from the Oregon Rural Practice-Based Research Network, Alexander Fiks, who is at the University of Pennsylvania and leads a pediatric research in office settings PBRN, and then Jackie Britz, who's at Virginia Commonwealth University and leads their practice-based research network, AHRQ. So you can please use the chat to ask any questions that you have. We'll cover questions once the 4 presenters have gone over their presentations, and then also hopefully engage some robust discussion back and forth as well at that point. So I'm gonna like to introduce our first speaker now, who is Asta Sorensen. She'll be sharing information from AHRQ's primary care practice-based research network publication that looked at work between 2014 and 2023. Welcome, Asta.
Thank you so much, Sebastian. And for those who don't know me, I'm a medical anthropologist and senior scientist. Been working with federal agencies and private foundations for over 20 years on implementation and evaluation of various healthcare innovations. And currently, I am a consultant with the North Carolina Department of Public Health. So today, I'll share a few highlights and some implications based on synthesis that summarizes primary care PBRN publications over the last decade. Next slide. So first and foremost, I want to acknowledge the team that contributed to this report, including current and former AHRQ staff, econometrica team, and 3 former Mathematica staff. Next slide. So the goal of the scan was to identify trends, topics, and impacts of US-based primary care PBRNs over the last 10 years. And I'll start by describing our approach and speak to a few limitations. So to identify PBRN publications, we began by scanning PubMed. And we quickly realized that there is no simple way to identify PBRN publications that can be attributed to them. While some PBRNs listed the PBRN affiliation, many did not. And at the time of the study, there was no relevant mesh term to denote them. So to get more complete sample, we proceeded with direct outreach to PBRNs, asking them to validate our list of citations, as well as identify additional publications that they might have. And 19 PBRNs responded to this outreach. To assess some organizational patterns, we integrated PBRN characteristics such as size, age, that are available on AHRQ registry data that Amy just shared. And we used Web of Science to identify citation impacts. So in total, we identified 100 US-based primary care PBRNs and over 900 citations. And due to high volume of data, we used automated deductive abstraction technique and manual validation to categorize them. Next slide. So as this figure illustrates, PBRNs consistently published over the last 10 years, as well as before, with a slight trend upwards in the last 3 years. And this chart shows data in 2 columns. The blue indicates publications of PBRNs that responded to our outreach and validated their citations. And the burgundy denotes all identified citations, including those of PBRNs that did not respond to our outreach. So next, I will describe the topics that they addressed. And we organized these topics into 2 domains, primary care transformation and clinical domains. So this slide shows the primary care transformation topics that PBRN publications addressed. And as you can see, PBRNs published on diverse range of topics on primary care transformation. Given the community-based nature of PBRN work, it's no surprise that the most commonly addressed area was community engagement. Other common topics were health IT, organizational culture and teamwork, patient safety, and patient and caregiver engagement. Let's address that might benefit from future research were care coordination and advanced care planning. Next slide. So on the clinical side, most commonly addressed topics were mental and behavioral health, including publications that focused on behavioral health assessment and interventions, substance use disorders, and treatments for depression and anxiety. Other commonly addressed clinical topics were hypertension, cancer screening, obstetrics and gynecology, nutrition, diabetes, and cardiovascular health. More recent publications naturally focused on response to COVID-19 pandemic. Clinical topics that were less addressed were those that focused on multiple chronic conditions and COPD. Next slide. So we also wanted to learn about funding sources that PBRNs receive. And as you can see, our data suggests that PBRNs heavily relied on NIH and AHRQ funding, with very few receiving funding from other federal agencies or foundations. I was a little surprised that now one publication identified CMS as a funding source, given several large primary care transformation initiatives that were taking place during this time. Things like multi-payer medical home demonstration, comprehensive primary care, CPC or CPC Plus, and a few others that involved thousands of primary care practices across the country. Another interesting finding is that a sizable share, almost 40% of citations, did not list any funding source, which might suggest that their work was supported by affiliate academic or healthcare systems. Next slide. So a few more observations in terms of PBRN characteristics. We found that those with larger networks, longer tenure, and academic affiliations were more likely to produce a higher volume of peer-reviewed publications, perhaps because they have more infrastructure support. And of the older publications, at least 44 were cited 50 or more times at the time of our review, which is getting a little dated. And there were many others, newer ones that were cited, highly cited as well. So note that citation counts in Web of Science were not available for all identified publications, so it's possible that we might have missed some high cited publications. And in the next slide, I would like to recognize some PBRNs that had most highly cited publications, those being San Francisco Bay Collaborative Research Network, Pediatric Research in Office Settings, ACORN, Ochsner Primary Care Research Network, and East Carolina Association for Research and Education. So in the last slide, I will wrap up with a few insights and practical observations that might be helpful for PBRNs in moving forward. Given the finding that most productive PBRNs were also the oldest, largest, and had academic affiliations, we believe it might be helpful if they collaborated with smaller and newer PBRNs to grow their capacity and assure that communities have that those communities have access to future opportunities. PBRNs might also have opportunity to explore topics of care coordination and collaborations with organizations that represent other care settings that are highly dependent on primary care. Given the current funding environment and high concentration of PBRN funding sources in NIH and AHRQ, I believe it's critical to PBRN sustainability, if not survival, to diversify the funding streams. That includes other federal agencies, but also local and state public health departments, foundations, and private sector sponsorships. And last but not least, clear attribution, clear and consistent attribution to PBRNs and peer-reviewed publications would increase the visibility and collective impacts of PBRN ecosystem. So with that, I'll pass it back to Sebastian and other speakers. Thank you.
Thank you so much, Asta. That was a great review of what PBRNs have been doing over the past decade or so. Next, we're going to have a presentation from Dr. Melinda Davis. Dr. Davis is the director of the Oregon Rural Practice-Based Research Network, or ORPRN. and the director of the Oregon Clinical and Translational Research Institute Community Program, and is a professor at OHSU. Welcome, Melinda.
Thanks so much, Sebastian. It's a pleasure to be here. So go ahead. My talk is going to be about 2 decades of development with the Oregon Rural Practice-Based Research Network, or as I was preparing this talk, I had some alternative titles. I didn't know this career was possible, and for ORPRN, AHRQ, and the PBRN community. You don't need to know where you're going, you just need to know the next best step. And then a tribute to David Myers, what would David Myers do? And as many of you know, David Myers was a leader at AHRQ from 2004 to 2024 when he passed. And not only was he a great researcher, thinker, kind of advocate for the PBRN movement, he also espoused the kind of core, at least of our network, of relationships and connection and continuity over time, both in the PBRN, but also I think in primary care. And you'll see that probably echoed in this presentation. And I'm just, again, so grateful for David and the support that AHRQ has provided, both for me individually as well as for our network over time. Next slide. So briefly about me, and I'm bringing my story up a little bit throughout this presentation because I think it helps demonstrate the full spectrum of work that can happen in a PBRN and the impacts that PBRNs can have on both individuals and communities. So I grew up in a rural area, and when I started with ORPRN, I actually had the opportunity to serve that area. And as a faculty member, I've really partnered with that portion of the state as well as the whole state to advance a lot of interventions to improve screening and prevention for chronic conditions. And the interests that I have around rural health, preventive care, participatory implementation science really blend with the approaches in practice-based research. But again, as I mentioned, when I was advancing early in my career, I really didn't realize this was a profession and a possibility. And so I'm so grateful for having connected with the PBRN community. And for any of you who are out there thinking about your own career, hopefully this can provide some strategies for you to think about how to engage and what the benefits of that engagement are. And the photos here, one is just of me as a very curious young person. And then the photo on the bottom is my sassy, almost 2-year-old. We had a late in life addition, and so that's also been really fun to see how that's shaping my research interests as well. Next slide. So both my work and the work that ORPRN does is really meant to bridge this gap. So the latest research shows that we should really do something with all this research. And as many of you know, this is a challenge. Moving discoveries into real world practice requires shifts and tailoring and adaptation and sometimes more implementation support than was in the original study design. Next slide. And to anchor that a little bit more, let me just give you a brief overview about ORPRN. So ORPRN is a statewide practice-based research network that was founded at Oregon Health and Sciences University. OHSU is based in Portland, but we serve the entire state. And our mission is to improve health for all Oregonians through community-partnered research, education, and health system transformation. And while we have rural in our title, in about 2010, we expanded to working with all clinics, including urban and suburban practices, because we realized those settings also struggled with implementation or quality improvement, or even sometimes accessing training. And as you can see, since 2019, we've worked with over 400 primary care clinics. That's about half of the primary care clinics in the state. We've worked with all of Oregon's CCOs, or our Medicaid accountable care organizations. We've reached over 5,000 unique learners in our education programs. As I'll mention, ORPRN is both a practice-based research network, but we host our state's Oregon ECHO network. So we also deliver multiple ECHO trainings each year. And then we've engaged 70,000 individual patients in different projects over time, as well as partnered with professionals and collaborators in all 36 of Oregon's counties. Next slide. So we didn't start this big. So I joined the network in 2007 as a regionally based practice facilitator. And if you look really closely at that slide with the 2010 picture, you can see myself tucked in the very back. And at that time, we were 13 staff with 3 regionally based team members. And we served about 49 clinics and 150 member clinicians. And we really were one unified program. But the team grew a lot. We grew a lot actually during the period of COVID, which is interesting. And to Asta's presentation, part of that was actually driven by being a recipient of the CMS Accountable Health Communities Award at the time and some other large grants. But currently we're about 55 staff with about 20 who are regionally based across the state. And we have many member clinics, but we have a profound number of members that have expanded beyond just primary care to engaging public health, health plan, and community partners. And as I mentioned, we've evolved, so we have a research arm, an education arm, and a health system transformation team now. Next slide. This is a selection of our field team. So one of the concepts many of you are probably familiar with, if you're familiar with AHRQ or practice-based research networks, is their regional practice facilitator model. And I have on my title slide that I also direct our CTSA's community program, because just recently we actually merged our practice facilitation model with our CTSA's community research liaison model. So what you see here are new community research facilitators who are blending the engagement with practices as well as communities, because that's in better alignment with how care is delivered now across the state in Oregon. We have some other regionally based team members, but I just wanted to highlight this staff structure because it has been so critical for continuing to maintain and build relationships and to know what local partners are interested in, so that when we have study opportunities, we really know where can those opportunities match and where might they be a good fit, as well as what are community partners interested in. Next slide. So I would really encourage you, if you want to learn more about ORPRN and our impacts, we started producing impact reports in 2019. And really just briefly, this report highlights various projects that we're active in. So you can see here that this is the report from last year, from 2024 to 2025. We were engaged in 82 studies and projects, and these span from, very small qualitative research projects to very large multi-site trials or center awards. We deliver about 35 to 40 different ECHO programs in any given year, and those span topics from substance use disorder to community health worker integration. And then we support numerous technical assistance events. And again, per Asta slide, we engage multiple funders. That's been a key to the success over time. Next slide. So in a given year, our total budget is around $9.3 million. And again, that's funded about half by federal awards, about a quarter by state awards, at least historically, and then another quarter from other funds. And that funding mix really varies across our programs, which I think is an important aspect. The other thing that I think is really critical is that our success as a PBRN is really based on collaborations with clinical partners across the state, as well as with academic partners, both at OHSU and in other settings. That can include experts across the state who are known in their own communities or spheres. Next slide. So I wanted to just briefly highlight my own pathway to independence. So again, I started with ORPRN in 2007 as a practice facilitator while I was finishing my PhD. And this slide starts with work I did early when I transitioned to a faculty role in 2011. And you can see that early work was actually expanding a lot of the collaborative structure that we did with our practices to working with these Medicaid coordinated care organizations and communities to understand not just how is care delivered in the primary care setting, but what are those supportive and complementary structures in the community. And through work with my community partners, we actually identified the need for interventions to improve colorectal cancer, specifically around increasing access and use of fecal testing. And this Finding the Right Fit study is one of my favorite studies, which was really a community-driven project to do patient user testing for various fit options so that the region could identify not just the most clinically effective fit, but one that was most patient preferred. And that kind of pilot work spun into work to look at clinical workflows, look at regional variation in screening patterns, to do some simulation modeling to figure out what are the most effective interventions. And this early work was actually funded by an AHRQ Institutional Career Development Award. It was later supported by an NCI Career Development Award. And then you can see we were able to scale up this intervention in a Access Moonshot Award, which is a UG3, UH3 large mechanism in partnership with 3 of our CCOs in the state, as well as nearly 30 rural clinics. And I attribute much of kind of the network success and this success to support early on from AHRQ, both in terms of our project activities, but also in terms of the methods we use for implementation and partnering with sites over time. And I'm very proud that our PBRN, as well as Sebastian and Allison Cole's PBRN from University of Washington, is now one of the inaugural Care for Health network research hubs, where we get to do community engagement, we get to support co-design studies, and to really integrate our rural practices into existing NIH-funded studies. So next slide. I share that simplified slide, and then I bring up this mess slide because, as Kurt Stange, one of my mentors, has said, careers only look linear in reverse. And so what you can see is that a lot of the work I was doing around colorectal cancer, there were parallel threads. And so in orange, you can see work around behavioral health and substance use interventions. In kind of the pink, you can see community engagement and participatory methods. In more recent years, you can see the gray, which is really around convening and using facilitation as a way to support implementation. And if you click one slide forward, I think it's helpful just to flag that across time, much of this work has been supported and shepherded by support from AHRQ. So next slide. So a few key impacts of ORPRN and AHRQ on my work. If you are a clinic looking to get engaged, or an academic, or in any way looking to get engaged, I just really encourage you to partner with your PBRN in your region or in the region that you're located, because of these opportunities to connect with clinics and to have relations that extend beyond individual projects, to have collaborations with academics, as well as community partners that anchor these projects to local needs, and then to, have the reward of community belonging and impact in your own life. Next slide. And key impacts of ORPRN's work. Again, we've done numerous studies that have enhanced better access to care for rural and low resource patients, increased quality, safety, and efficiency, reduced variations in care, improved provider retention, supported dissemination of best practices, and supported identifying and addressing questions from practice and relevant to practice. So I'm going to end with just 2 cases really briefly. So next slide. And I think these illustrate the benefit of partnering with a PBRN and the impacts on research design. So I'll just read these and then speed through. So a seasoned researcher seeks to enhance diversity in their pragmatic clinical trial. They start cold calling federally qualified health centers across the state. After 6 months, they've enrolled 1 clinic. After 12 months, over 200 patients have been eligible for the study, but only 5 were recruited. Moreover, the researcher is unable to access data from the electronic health record on enrolled patients. The clinic medical director is frustrated and advocates to avoid studies with the researcher's institution. But in contrast, in the next slide, sorry for the density here, but this is a case that is a composite of various projects we've supported, where the same researcher has a new idea, but now realizes working with community clinics is outside their expertise. They present their idea at the CTSA's design studio and are referred to a PBRN. The PBRN team helps refine the study design, data collection strategies, clinic impact fees, and they transition participant recruitment to both visit-based and population outreach strategies. The researcher adds the PBRN director as study MPI and funds regional PBRN staff. Based on input from the PBRN's advisory board, they align outcomes with a state quality incentive metric. Using PBRN data, the team identifies and approaches 4 clinics. Within 1 month, the same FQHC agrees to participate. Within 3 months, PBRN staff are embedded in the clinic supporting participant enrollment, data collection activities in alignment with clinic workflows. The PBRN team has also helped refine EHR documentation to support process and outcomes reporting. Within 9 months, the participant recruitment target has been met, despite transitions in the medical director and multiple clinic staff. The project is celebrated by the FQHC leadership, who are eager to partner on the next study. Next slide. So the network director, LJ Fagnan, I'll leave you with 2 quotes. Doing primary care research in an academic medical center is like doing forestry research in a lumber yard. And for your clinicians out there, a quote from my partner who said, "I never thought of them as research questions. I just thought of them as something that could wreck your day." So final slide. Thank you so much. It's been my pleasure to share as part of this panel.
Thanks, Melinda. It's great to hear kind of your story and journey through your work at ORPRN. Next, we will have our third presenter, who is Dr. Alexander Fiks. Dr. Fiks is the director of the American Academy of Pediatrics Pediatric Research in Office Settings, or PROS PBRN, and is a professor of pediatrics at the Children's Hospital of Philadelphia. Welcome.
Thanks so much. It's really a pleasure to be here, and I feel like being on these webinars with the PBRN community is like coming home and celebrating a terrific body of work across different settings with huge impacts. And thanks to AHRQ for their place in this. And I appreciate the shout out to all of the PBRN leaders who've contributed. If we go to the next slide, I'm here representing Pediatric Research in Office Settings, which is the primary care national practice-based research from the American Academy of Pediatrics. If we move to the next slide, there's some really interesting things about PROS and its history that I think are relevant to understanding PBRNs in general. First, the program, in an effort to mesh practice change nationally with the ideas, innovations, and insights that come from research, PROS is embedded in the American Academy of Pediatrics. Our focus since our founding 40 years ago has been on primary care, with a mission to improve the health of children and enhance primary care practice by conducting and fostering national collaborative practice-based research. That slide on the right, the text may be a little bit hard to read, but I just want to shout out the founders of our network who in 1985 came together and had this keen insight that when you marry the academic strengths of investigators from great universities with the insights of practicing primary care and other clinicians and their communities, you wind up with a very powerful force for advancing healthcare and healthcare delivery to our patients and communities. On that list were people including Barbara Starfield, who many credit as perhaps the mother of primary care research, and Richard, also known as Mort Wasserman, who was an inspiration to the formation of PBRNs in many regions of the US. On to the next slide. So what has our productivity been like? We've had more than 50 studies since 1986, 135 peer-reviewed manuscripts with 26 since 2020. One of the real strengths, as I alluded to earlier, is this interdigitation and weaving of the results of this research with the American Academy of Pediatrics and its guideline producing and practice informing supports. And so our work's informed national guidelines for clinical practice in areas like antibiotic stewardship, obesity management, the care of those with hypertension and hypertension screening, and a host of other conditions. And our impacts on practice have included how child abuse screening is done, child safety and injury prevention, again, obesity treatment. We discovered the early timing of puberty in boys and girls, which changed the public understanding of those conditions, of that sort of normal life course change. We found that children who were being too intensively managed when they had fever in many settings in infancy, and decreased the intensity of evaluation that was needed for that group. And also recognized that vision screening, which had been at the time starting at a whole wide variety of different ages and in different ways, if standardized and begun at age 3, could be effectively completed and potentially change blindness because of the prevention of amblyopia. This range of projects is a celebration of PROs, but it's also a celebration of the work of PBRNs and how PBRN research can be so meaningful to the care and understanding of health and well-being across the population. On to the next slide, please. So PROs, this is our map of practices. We've had nearly 500 sites involved in research between 2010 and 2026. All regions of the US are represented. There's a chance to do studies through our network in urban, suburban, and rural settings. And that heterogeneity allows us to see how the uptake of different interventions might vary in those locations. And again, more than 450 practices and a population that we've been able to determine as similar to the 2020 US Census. So in terms of generalizability and ability to reach people across wide varieties of demographic groups to make a difference. Next slide. One of the key insights, as I mentioned earlier, is that weaving together academic expertise and resources from academic medical centers with the wisdom of clinicians, as well as insights from families and other community members and stakeholders, can accelerate research that winds up being meaningful and impactful in practice. Toward that end, PROS has a history of bringing together a steering committee, which provides initial approval to all projects. That steering committee includes both parents and practicing clinicians, as well as representatives from various leading groups around the US, including those focused on enhancing the mix and reaching all children in the country. And then there are 41 pediatrician coordinators now, actually a few more, from across the country who ultimately vote on and approve any project. So as opposed to stakeholder engagement being an afterthought in what we do, it's actually fundamental and critical to the start of any project in the network. And those groups throughout the course of studies and what's now common, but what 40 years ago was really unheard of, provide feedback, advise study teams, and really help shape our network's agenda. Next slide. We also work in PROS in an electronic health record data sharing consortium called CER Squared, which set out the long way comparative effectiveness research through collaborative electronic reporting. Excuse me for a sec. That network includes more than 3 million children and more than 223 primary care and family medicine practices. And so for those, there was a question in the chat, PROS does work quite often with family medicine and share insights across those settings, reaching into primary care for children wherever that may occur. You can see the map of practices in the network here, which is also another strength, covering much, though not all, of the US. On to the next slide. It's my pleasure now to highlight a couple of areas that have been foci of research for us, just to kind of show the types of insights that even recently continue to be generated by this research. So this is a study by Stan Gabczewski, who's an allergist at the Children's Hospital of Philadelphia, who had the insight that we know that there's a hypothesized allergic march where different allergic conditions unfold and appear over time, but exactly when those peak and how they're staged wasn't fully understood. So he took this electronic health record data, looked at the peak incidence and timing of these different conditions, including atopic dermatitis, IgE-mediated food allergy, asthma, one of the most common chronic conditions in childhood, allergic rhinitis, which right now is, I think, affecting many of us, and esophageal esophagitis, and was able to show how that march unfolds in a huge population of children across the nation. This kind of work, again, is made possible by the investments in practice-based research. If we go to the next slide, this was a follow-up study that Stan did this year that looked with increasing evolution of clinical practice guidelines around early food introduction informed by the landmark LEAP study, what happened in the real world in terms of changes in peanut allergy and any IgE-mediated food allergy over time. What that work showed is marked reductions that occurred accompanying initial changes in guidelines and an even more lax guideline for food introduction that followed. And if anyone has any doubt about the impacts of this work, please go to the next slide. This is features about this work in the New York Times from earlier this year, in the Washington Post, and in a first for our network. This research was also featured on Saturday Night Live, of course, in the news segment. On to the next slide. We've also been highly engaged in obesity-focused research now for more than 20 years, starting with a healthy lifestyle pilot focused on reducing pediatric obesity, extending into the motivational interviewing and dietary counseling for obesity study funded by NIH, which showed that motivational interviewing for obesity can make a difference. I'll show more results later. And then to the just completed BMI Square 2+ study called Brief Motivational Interviewing for BMI, which was again NHLBI funded. If we go to the next slide, that initial study, again, which changed practice by finding that when pediatricians delivered motivational interviewing in the context of obesity counseling and in partnership with dietitians, kids did better in terms of weight. So there were 3 arms in that study: pediatricians delivering MI without outside support, pediatricians delivering MI with local dietitians who supported that process, and usual care. The study involved 645 children. They were 2 to 8 years old, and they all had BMI over the 85th percentile. The group, and what was found was that group counseled by pediatrician and respiratory, the registered dietitians had significant decreases in BMI scores compared to usual care. If we go on to the next study, this one done during the pandemic, this had a goal again to reduce BMI among children 3 to 12 years, so slightly different age range, with BMI above the 85th percentile, a cluster randomized trial, a common design in our PBRN work, with 18 pros practices randomized to the intervention or usual care. And we found in that study that actually the counseling, so there were 2, there was in-office pediatrician motivational interviewing. There was a centralized dietitian who did tele-counseling around nutrition and obesity prevention. And then text messaging enhanced the messages by sending key ideas and reinforcing them around diet and physical activity goals. The primary outcome was reduction in BMI. And if we go to the next slide, what we ultimately found was that BMI offered by pediatricians and centralized dietitians didn't work to achieve healthy weight. The results were contrary to 2 prior studies. Both groups gained weight, but much of this work was done during the pandemic, which hindered the doctor-patient relationship, how care was delivered, how children ate, and how they could be active. So again, this is PBRN research showing how important the context is. And thanks to folks, I saw there was a question around where PROS was headquartered, and that was answered. Yes, we're based out of the American Academy of Pediatrics, which is in Itasca, Illinois. So on to the next slide. I wanted to thank you very much. We really encourage everyone participating to join our mailing list. We look forward to inquiries about possible studies, partnerships, collaborations, and ideas. And once again, it's a pleasure to be part of this active, impactful, and critical community for our nation's health. Thanks, everyone.
Thank you so much, Alex. It's great to hear an example of a national PBRN with a specific focus like pediatrics. And last but not least, we're turning to Dr. Jacqueline Dritz. Jackie is a clinician researcher and family physician based out of Virginia Commonwealth University and the co-director of the Virginia Ambulatory Care Outcomes Research Network. Jackie, I'll let you take it away.
Wonderful. Thank you so much, everyone. Hope you all have steam for one more presentation. So I am a family physician at Virginia Commonwealth University, co-direct AHRQ, and really excited to tell you all today about the work we're doing in Virginia on practice-based research. My background was in anthropology before medicine and public health. I did health policy. And what I love about my job is I can integrate all those different perspectives with my love for community engagement. Before I get started, I wanted to tell one story, because when I think about PBRNs, I think about how they can represent and give a voice to primary care patients, clinicians, and staff. And so I think it's important to remember that patient perspective. So one story as I was putting this presentation together that really came to mind was I was on call on Thanksgiving and a patient called in and they reported hypoglycemia and their sugar was really low. Normally it would be a pretty straightforward phone call. Ask them to have crackers or toast, recheck their blood sugar later on. But they told me that they didn't have any items of food in their house, not one item. And on Thanksgiving Day, there was a lot of limited resources to get to them that day. And I found myself heartbroken for the situation that they were in and also frustrated at the system that, I was debating, do I need to send this patient to the emergency room for something that is so preventable and something that could be so easily treated in a different setting. And fortunately, we were able to get food delivered to their home and everything worked out okay. And we have an incredible social worker who followed up and got them all the resources that they need. But for me, it flagged a few different things. One, that patients often come to their primary care providers first, and that primary care clinicians across the spectrum often have a window into the lives of patients within the context of their families and their communities, and that voice is so important. As we think about primary care, there are so many wonderful things happening, but there are a lot of challenges. And I think PBRNs can provide a really powerful role in being the voice of primary care and reflecting those experiences of patients, clinicians, and staff, and making sure that we're making changes and that our research is reflecting those voices and also that we're enacting change. So on the next slide, I'll go ahead and get started. The next slide, actually. Yes, so this is AHRQ. So we have primary care practices throughout the state, rural, urban areas, small practices, large practices, health system owned, direct primary care, kind of the whole footprint. And each of these practices, each of these dots represents a practice with clinicians, patients with stories just like that. And our priority is listening to those patients and clinicians to make sure that informs our research. Next slide. So we were established in 1996, and we were one of the original AHRQ-funded PBRNs. We have received about $20 million in AHRQ funding over the years for a variety of different programs and projects. And so really grateful to AHRQ for helping to build our infrastructure to do research on so many different topics. We have over 500 member practices. That's 1/4 of primary care practices in the state that have participated in research over time. Next slide. And this is the real key to our success is a multidisciplinary team. So we have a variety of clinicians across pediatrics, family medicine, OBGYN, psychiatry, we have psychologists, we have medical anthropologists, biostatisticians. The core of our team is our research coordinators and our community engagement specialists. And we partner within our team, but also well beyond across the institution and across other partner organizations outside of VCU. Next slide. This is a photo from NAPCRG. So this actually shows a lot of folks that are working with our team, including our students. So a big priority for us is building the future of primary care research. And on the front there are our eager students who came to NAPCRG with us. Next slide. One core activity that we do every year is identifying every primary care clinician in practice in Virginia. And this may sound simple, but it can be really challenging to define primary care and identify who is a primary care clinician in practice in Virginia. And so we triangulate a variety of data sets, including licensing data, claims data. We then manually verify and nest clinicians into practices to make sure we have the correct denominator, that we're understanding who primary care is, where they're located, what they're doing. We then survey these practices every 4 years. And in this survey, we ask about challenges, what their priorities, values are, how can we support these practices. We also do qualitative interviews. Next slide. Some key activities just in 2025. So we have supported 16 trials with $55 million in funding. We have submitted publications, grants. We're highly integrated with the Wright Regional Translational Science Center, so our local CTSA. And we really, core to what we do is having an advisory board. So we have a clinician and a patient advisory board. That story I told before, there's so many stories within primary care and experiences, and we want to make sure the research we do reflects the priorities of patients and clinicians and staff. We also support the Virginia Standing Committee on Primary Care, and we work closely with the Virginia Center for Health Innovation to make sure the research we're doing is creating action. So we want to make sure to share our research findings with policymakers and those who are doing advocacy. We're going to be helping with the rural transformation grants as well in terms of evaluating the progress of rural transformation grants. AHRQ has a lot of different domains of research. So this has evolved over time. And that's one thing that we really noticed as I was putting together this presentation, is that our priorities have shifted based on the challenges facing primary care, based on the priorities of clinicians and staff, and really based on the changing healthcare landscape. We would say that our mission is to conduct research that matters to primary care, and that varies across chronic disease, measurements, informatics, advancing primary care management, and practice facilitation. I also group the domains into these different bucket areas. So thinking at the patient level, we do clinical trials. We're looking at sinus infection studies and multi-cancer detection tests. But then at the clinician and the practice level, we do studies on practice facilitation, understanding unhealthy alcohol use and unhealthy substance use. What are the challenges facing primary care and how can we address those? We have research at the health system level, and that's largely to look at primary care workforce shortages and how can we address those shortages. And then finally, at the community level, that's a really broad category of research we do. One study I'm excited about in particular is our work on opioid mortality. So that was we partner with the Opioid Abatement Authority in Virginia, and we are essentially tasked with creating an evidence-based toolkit to guide the spending of funding across Virginia. And this is meant to make sure that funding is going towards communities that need it the most, and that we are helping cities and counties to design programs to address opioid mortality. But fundamentally, this has helped us to create partnerships and linkages across the entire community, folks that don't normally necessarily work with a PBRN that are key parts of our entire process. So going through each of those levels, I'm going to give a couple of examples of studies. So at the patient and clinician level, this is an AHRQ-funded practice facilitation study. So we did practice facilitation to help primary care practices better screen and treat unhealthy alcohol use in the primary care setting. And this was supported by Evidence Now, and AHRQ was a fundamental champion for this work. We enrolled 76 practices. They were highly represented. They provided care for people in 97% of the census tracts across Virginia. And essentially, we provided training to clinicians and staff on what are the evidence-based screening tools, how to better screen, how to work through their own primary care practice level processes and unique challenges in their own clinics, and then how to link those patients in with care. And it worked. So we found that practices that completed practice facilitation, they saw over 400,000 patients a year, and they observed a 33% increase in screening with recommended screening instruments. So what does that mean? So that accounts for basically over 100,000 patients will be screened annually for unhealthy substance use, which is 1% of Virginians. And that will result in earlier identification of unhealthy substance use, including over 8,000 patients identified and over 5,000 receiving brief interventions for alcohol use. We are now expanding this study. So Sebastian Tong is actually the PI for a study called SUSTAIN. Our team partners with UW, and we essentially are expanding this to improve screening and treatment for all substances in the primary care setting. And that's also an AHRQ-funded study. So shifting gears a little bit, one of the other domains is to help primary care clinicians and practices better provide high quality primary care. And so when I talk about high quality primary care, I'm referring to the 4 C's of primary care, looking at first contact, can patients access their doctor, continuity of care, comprehensiveness of care, and coordination. And what we found is that primary care practices, when we do surveys and interviews, they report significant challenges in providing high quality primary care due to massive administrative burdens facing their practices, whether it be documentation, prior authorizations, peer-to-peers, all these different factors. Also, patients may be increasingly complex and there's a lot of needs on the patient end. And so trying to juggle all these things can be very, very challenging. PBRNs can identify frontline successes and challenges to better support primary care. And so what we're trying to do is map out these 4 C's across Virginia to figure out where are things going right, where's high quality primary care being delivered, and we call those areas bright spots or communities that are doing better than predicted, and where are communities struggling, where primary care practice is struggling, and what are potentially the systemic factors across reimbursement or systems that we can help gain awareness for and provide additional support for. Next slide. And so as part of that discussion, we need to think about primary care shortages. That high burnout and turnover it contributes to primary care shortages. So this is a study done by Hannah Shadowin, who is an M.D. Ph.D. student in our department, speaking of the future primary care workforce. And she found this map here. Maps out the deficit of providers across Virginia. So looking at primary care clinicians across Virginia, there's huge deficits, unfortunately. But the exciting thing for her research is that she was featured in the news. She was interviewed for TV to essentially gain awareness for this critical issue. We have, on the next slide, we've done a deep dive into this data. And what we found is over 1,200 more PCPs are needed today for every Virginian to have a primary care physician or clinician. And that's based on what we know of our primary care workforce in Virginia. So these numbers are much higher than prior estimates, but our local data allows us to get a better estimate of the increasing needs over time. And this does not account for an aging workforce, including that 30% of PCPs currently are over the age of 60, so may have a reduced panel or may retire in the upcoming 5 to 10 years. Next slide. But there's good news. We have a lot of residencies who are within our primary care, our PBRN. And we looked at graduates from the VCU Family Medicine residency, and we found that over a 3-year period, these graduates had provided care for over 1 million Virginia residents. So graduates tend to stay in Virginia and they tend to care for Virginians, which to me was very exciting. Next slide. So shifting gear to that final domain, so that community health, so the last but not least, as we think about community health and how do we promote community health, we really rely on our community advisory boards. So we've asked our boards what is important to them, and they've identified opioid mortality, obesity, colon cancer, cancer screening, a variety of topics across the spectrum that you might expect. And so, but our goal is to not just map these out and see where the prevalence is higher, but actually how do we have solutions, potential solutions to these different challenges in our communities and help clinicians understand their local context, but actually make progress in these issues. And so we use a methodology called bright spot work. And this is essentially identifying communities that do better than predicted on a particular public health topic. So we've done most of this work relating to opioid mortality, essentially looking at where in Virginia are rates of mortality better than we would expect them to be. So despite having high levels of poverty or disability, where are communities thriving? And on the next slide, you can see that the blue here are bright spots. These are communities doing better than predicted. Red are challenge spots, communities doing worse than predicted. The size of the dot is the magnitude of the bright spot, so how much better than predicted they're doing. And you can see that just with this one public health topic across Virginia, despite very high opioid mortality rates, there are communities that are thriving. There are communities that are doing really wonderful work. And we can investigate these communities and learn some of the promising strategies and successful strategies that have been working. This helps inform our partnership with the Opioid Abatement Authority to flag what are things that are working that could be scaled up so we can prioritize limited resources, but also where are communities struggling, and are there systemic factors or local factors that we can help to address to help these communities. We are now redoing this process for those 10 other topics I mentioned, including primary care. And so we're looking at which practices across Virginia are thriving that we can learn from those strategies, and which ones are really struggling that may be systematic factors that we can help to gain awareness for and improve capacity. Next slide. So we think about why this all matters. Why does PBRN research matter? I think that it can have a huge impact. PBRN research can help us understand the value of primary care, the broad spectrum of things that primary care clinicians and staff do, and the impact of this. It can help us support primary care practices, so help clinics understand their local metrics, understand their local data and community health data, and respond appropriately. Help clinics access resources. How do we use novel technologies, AI, and monitor the impact over time? We can also strengthen high-value primary care, so learning from these successful models or bright spots and scaling it up. So really doing innovative research and transformative research. How do we design care teams, reduce burdens on primary care, and ultimately, how do we translate this at the larger scale? So really engage in advocacy to improve supports for primary care and resources for primary care. So our goal with AHRQ is to serve primary care by knowing primary care, and AHRQ, I think, can play a really key role in supporting transformational research to help support the future of our primary care system. And I'll finish there. Thank you so much for your time.
Thank you so much, Jackie. That was an amazing overview of all the great work you're doing in Virginia. Now, I think we've had a lot of information. Now it's time to engage with all of you in the audience. So I welcome anyone to put in questions into the chat. We see that there are some already in the chat that we'll shortly address. But before we get to your questions, I just have one question to start with for all of you to reflect on. We've heard a lot of great information about the work you've done. We've heard from Asta, the work that AHRQ has done over the past 10 years to support PBRN research and the directions for that type of work. So AHRQ continues to be has a statutory charge to be the federal home for primary care research. What do you all see as kind of the next steps and priorities that AHRQ can do in practice-based research to advance the field, to advance whole person health?
Well, I can get us started. I will say that historically, AHRQ has played a critical role in funding really important and transformative PBRN work. And so I think there's opportunities both short and long term. Short term, I think there's opportunities to fund AHRQ-funded projects that may be on hold. I mentioned that SUSTAIN project that is looking at unhealthy substance use. It's currently paused due to funding, but that type of research I think would really move the needle in terms of substance use. But longer term, I think there's an opportunity for AHRQ to lead the expansion of PBRN research and advance whole person health, including efforts to build sustainable programming and local capacity for PBRNs. AHRQ is charged with studying implementation of care, patient safety, information technology, all these things that are so important. So I think there are critical issues that need funded research that AHRQ could really lead.
Other thoughts of panelists about kind of the directions AHRQ could take in the next decade, I think, so that we can be back here in 10 years looking at how to move things forward?
I love what Jackie said. I think the other thing is just continuing to advance team-based models of care, and how do we support team-based models of care in these settings. I'm actually in a rural community today after a site visit, and it's just amazing the work they've done to provide services in a community of 6,000. And part of the reason they've been able to do the work is because of their partnership on multiple AHRQ studies, but other studies that have implemented team-based care for substance use disorder or for chronic pain management, or doing some novel work around blood pressure management with pharmacy partners. And so, AHRQ has always been a real leader, I think, in this space of identifying evidence-based interventions that work, and then standing up pilots to help implement them and see what works across different settings and communities. So I think the more we have the opportunity to leverage AHRQ as a way to scale effective practices across the diverse clinics and communities we serve, that would be ideal.
I might just add that, historically AHRQ has been such a great convener and organizer of PBRNs where insights from one can be shared to others. I hope that that role can continue. And of course, project funding is sort of the fuel that keeps the research going. And, I think all of us in the PBRN community hope that AHRQ can maintain that partnership with us.
And I'll add that I hope our continuous focus on implementation science. A lot of what we heard today is really based on implementation science concepts, and that as they launch new studies, that they pay attention to sustainability early on upfront and really maximize those concepts. So again, not losing that focus.
Thank you. The next question I have is one that Lloyd Mitchner put in the chat earlier. They're coming from this angle of NIH CTSA's community engagement. And their question is how to better link CTSAs with PBRNs. And I'll add kind of with that, like there's other NIH mechanisms that are out there as well, like CTRDs that are coming from NIMGS, I think. And then also the new Care for Health initiative from the coordinating center and director of the office. How do you see PBRNs kind of linking together with these initiatives at NIH, and how do they kind of synergize with each other?
Happy to jump in a little bit on that since I direct our community program for the CTSA and our PBRN. And that has been a real, I think, fortunate partnership over time. And Lloyd, I just direct your attention. We did a CTA and PBRN partnership study. The first one was published in 2010. I think there's another that was published in 2017. And I think that's actually being updated by Jonathan Tobin and partners. And I'll just say there's a lot of variation in terms of CTSA and PBRN partnerships. And maybe doing something like Jackie's team has done with Bright Spots could really help identify what are the factors or levers in place for these more effective collaborations. But what I will say is we definitely don't want to create in parallel in these communities. And so I think what you're flagging in terms of how can we align CTSAs with existing infrastructure is really critical. And one of the, I think, most effective ways to do that is through mechanisms like the Care for Health initiative, where they identify that if you're going to apply, you need to be partnered with the CTSA or partnered with a certain infrastructure. And I could see something similar for the CTSA RFA, that they would encourage collaboration with existing PBRNs. So I think there are some mechanisms from the funding, but I think there's also just this important advocacy at our institution. We've really worked to align our our Cancer Institute, our CTSA program, and the PBRN infrastructure, recognizing that collaboration is in the best interest of everyone. Otherwise, you're going to end up bumping up against each other and competing in these communities in an environment that's already stretched thin. So I don't necessarily have the answers, but I think there are a lot of places we can look for those bright spots and what has worked.
Will echo, at least at VCQ, our collaboration between the CTSA and our PBRN has been just instrumental. It's been really incredible. And there's a lot of overlap in staff that work between them. And I think that's helped as well as making sure we're meeting regularly and knowing what each other are doing. But that has been really incredible. So ways to formally strengthen that relationship between PBRNs and CTSA, I think can only increase and strengthen community engagement and capacity.
Great, thank you. The next question I have is from Greg Gilbert, and they have a question about have any lessons been learned from non-primary care-based PBRNs like to be applied in primary care, or I would say vice versa as well. I know kind of our examples have been from the primary care space. Do you have any kind of experience working with non-primary care PBRNs, and how does that look like?
I don't actually have a ton of experience partnering with specific PBRNs. We did a collaborative study with a dental PBRN a number of years ago to look at unmet dental needs in primary care because both partners were curious about that topic. And then we've been doing a lot more with pharmacy experts, but less with the PBRN infrastructure and more because those are roles that many of our clinics are starting to integrate. So I might ask back to the person who asked the question, if they're thinking of any seeds they want to plant, feel free to put that in the chat because I'd be curious what's on their mind about kind of opportunities or lessons learned.
Adding to that, I think there's a question in the chat or maybe a comment about how we can really make the case that PBRNs need more investment than inpatient infrastructure, even because of the complexities in getting research out to families and community settings. I think one of the challenges and the link to this particular question is that when we try to do studies that pair multiple PBRNs, the budget costs of conventional funding mechanisms don't usually sustain those kinds of collaborations. And so it seems that much of the specialty work related to primary care comes not from marrying specialty networks to primary care networks, but by bringing specialty expertise to the primary care network and look at questions relevant to the specialist with that framing. I'd love to see projects that were even bigger and more expansive where there could be combinations, but that seems to be the biggest way it's going right now. But again, that need for funding to support this grander vision of collaboration and impact, and to even maintain the ongoing research in community settings is critical.
Our next question that I see, thank you so much for everyone's thoughts. The next question I see is from Ray Hamey, and they're talking more about engagement, which is, I think, core to what we all do in PBRNs. And I think they saw kind of in our presentations talk about advisory panels, and their question is, how about patients and community members actually participating as part of the research team, and what does that look like?
I mean, I can say for pros that since our inception, we've had practicing pediatricians, which for our practice-based community is sort of from around the country critical, be members of the research team. It's a long tradition, and it's led to a whole host of insights in terms of how projects are implemented and evaluated. And I think thanks to the nudge and explicit support from PCORI, now patients, families, and other stakeholders are playing greater and greater roles on teams, and NIH has moved in that direction, for example, with the Recover initiative that we've been part of, and it creates a different perspective on what should be prioritized and how interventions or other projects can be implemented to make the biggest difference. So I applaud it, and I think all of those mechanisms, you know, having it be a fundamental part of the PBRN and then taking advantage of project-specific funding can help get us across the finish line with that, you know, to enhance engagement.
I'll just build on what Alex said. I think that's really wise. We have some, you know, we have an advisory board as well. We have clinical members who are common partners in our research activities. And then we're always trying to think about how do we build that capacity for specific studies. So topics interest different people. And so that gives us an opportunity to think about kind of how do we engage different patient or community member partners. And I will say the Care for Health initiative has been really helpful because as one of their principles, they really want their studies to be informed by community and clinical practices. And so we've had the opportunity to do a lot of outreach and engagement, and even in the structure of the collaborative work, it's designed kind of like PCORI, it's designed to have partner input. So in some ways it goes back a lot to funding, because Collaborative development, I think, has really profound impacts long-term, and collaborative development can take real time up front, be it with other PBRNs or with patient or community partners. And so investing in that critical infrastructure is really important and shouldn't be overlooked.
I'll add that at VCU, I love that question. We've been able to, advisory groups are wonderful, but being able to engage them in a really meaningful way in the research process is a different level. We have started doing that through making what we call topic teams. So the advisory board is more broad, but when we look at like the opioid example, we have 10 individuals on a topic team for opioids, and they are clinicians, they are patients, families, individuals, lived experience, researchers, and they are weighing in on the research process as it goes on. And we kind of do some work, we bring it back to them and say, what do you all think? Are we going in the right direction? They help us interpret our findings and make sense of it and challenge us a little bit to look at things in a different way. And so it's this iterative process over time. And the second way we're doing that is through, there is a study funded by AHRQ, actually run by Dr. Emily Zimmerman, that aims to train individuals with lived experience with substance use to join research teams. And so it goes through training on research and also advocating for themselves and joining these teams and being able to provide their perspective, with the goal of having individuals being on all teams related to opioid or drug related research. And so that's another cool way of seeing that formal training happening as well.
And in foundations landscape, we're seeing some paradigm shift in how patients and communities can be engaged, from not just being participants, active participants, but actually driving research. So I think a lot of new models are emerging that are kind of innovative and new from what we used to traditionally, and how we engage patients and communities.
Thank you. I see two questions kind of about how we incentivize or resource sites and participating clinicians. So what incentives do we provide to primary clinicians? How do we resource sites that are part of our PBRN? And I think that builds on kind of Aliana's question about how can we make the case that PBRNs actually need more funding for infrastructure as well? So if someone you could address kind of that kind of series of questions.
I think it's a, go ahead. Okay, to start, I think it's a tough ask for a busy clinician, MPs, MDs, RNs, to add something to their schedule. And so it can be a really tough sell. I think the ways that we found that be helpful is to develop long-term relationships over time. And to emphasize how this impacts clinics. So we're trying to learn from them about the frustrations they may have, to get to Melinda's, quote from earlier in the presentation of, these challenges they're facing, we can research them and help improve them. And so I think over longitudinally, when they've seen benefits from the research itself, it's helped. And also we try to make the lift as low as possible. We try to do as much as possible to make it really easy for clinicians. We also have, there's, gift cards and things of that nature, but I think that the real value is building that longitudinal trusting relationship. And then academia, we have kind of separate incentives to incentivize our clinicians to do research through their academic role as well, to include them on publications and presentations and things like that.
Yeah, I love that anchoring in the relationship. And I think that goes to study co-design, of really designing studies that hit those pain points for these partners. And so it's a direct benefit to the clinicians as well as the staff. We often hear that it's staff that are really important to engage in this work too. And it can be a real lifeline for helping those staff develop supports. Financially, what we often do is we'll have impact fees for the sites for participation, or, studies. Again, in that budget, it can span a whole spectrum, where for some studies you can actually fund a position like a nurse care manager. And for others, you may try to do the light touch, minimal disruption because the budget doesn't allow it. So I think there's a lot of flexibility in how we approach this, to try to kind of harmonize the ask with the actual context, and as much as we can really contribute real resource to those sites, either in terms of an impact fee or a person. So not just asking for more, but really recognizing changing practice, delivering these new models of care requires people. So maybe to Asta's point about implementation science, like implementation science doesn't just mean adding on, right, without new resources. So I think we need to be thinking about that too, and setting these sites up for success, and the PBRNs who want to partner with these sites.
I totally agree with what Melinda and Jacqueline have said. You know, I think one of our founding mantras is the work has to be a solution to someone's problem, and the real way to add value is to bring research that helps address key problems that clinicians are facing in practice. I feel like no grant or effort is big enough to actually pay clinicians what they would necessarily be able to earn if they just focused on seeing patients or doing some aspect of that work. So that value of actually meeting a need that they have is critical. And then trying to engineer and design studies so that they don't burden frontline clinicians, but as was mentioned, whatever possible can fall on the research team, or now increasingly different systems we have, whether that's technologies or other approaches that can augment as opposed to add burden to what's going on at clinical sites.
I would like to suggest physician engagement as a topic, kind of wrapping back to where we started, what AHRQ could fund and look at. I think understanding physician engagement, clinician engagement, challenges that they face and what can we do about it would be very important line of inquiry. And some of the large primary care transformation initiatives and evaluating implementation, we observed that about a third of physicians not only weren't involved with changes that were taking place in their practices, some of them were not even aware. It was just a check for healthcare systems, for healthcare practices, and that's how change does not happen. So I think it's a very important area. A lot of work's been done in Europe and Canada. I think this is something that would be worthy to pursue for AHRQ.
I'm just going to close with one last question, and I should have warned you about this beforehand, but I wanted to hear about one thing that gives you hope in the work that you're doing. And I can share that one thing that gives me hope was recently going out to Idaho and going to a listening session and hearing from clinicians about why they're engaged in research and the impact that research has had in their patient lives and how it's improved their ability to take care of patients.
Tempted to run to my notebook because at a dinner last night with a clinical partner, we were asking her, why are you still engaged with research, or why is your clinic so different? Why are you so interested in research? And she said, you know, it allows us to do things that we wouldn't otherwise be able to do. And so it allows them to achieve the vision that they have as a practice, as a setting that can really provide that whole person care and address the needs of the population that they serve. And so I think that what gives me hope is just engaging with our partner sites and occasionally having an opportunity to help them out.
What gives me hope is looking at some of those bright spots. There's incredible work happening and people are engaged and excited. As I've seen questions about different payment models and addressing shortages, there's a lot of things that are working already. And how can we learn from things like that and scale it up? And then also our very eager students. There's a lot of people that are very interested in primary care research, and that's really exciting to see.
I'd add that, you know, I'm inspired by the fact that hundreds of people signed up for this webinar and are still invested in PBRN research, that technology is advancing and bringing new treatments and approaches to patients, and we need to figure out how to do that in the best possible way. That we thought when our older generation of involved clinicians became more senior and retired, that there might be a deficit of younger, enthusiastic clinicians who were interested, and we found the opposite. An incredible wealth of wisdom and enthusiasm and commitment for this work that inspires me. And I'm sort of inspired by a quote from one of the participants in a recent study we had, who thought it was one of the most inspiring parts of her career, what she learned and being able to apply this novel intervention. It was a communication focus to how she talked with patients and being able to see the difference. And so all of those stories and realities show that there's a lot of momentum behind this work, enthusiasm, and the potential for continued impact.
what inspires me is to see that, again, momentum, and that new funders, foundations in particular, new entities that did not traditionally funded this work are getting very excited. And that, again, every problem creates new opportunity. As we lose some funding sources, there are some new ones that coming up that we're going to hear very soon about. And that's what inspires me.
Thank you everyone so much for participating in this panel. We will send out a brief evaluation poll after this webinar, but we are just so excited that you were part of this and excited about the work we're doing. Thank you so much for being part of this.
Thank you.
Thanks everyone for taking time and joining.
Thanks so much.